Thank you for inviting me as speaker. This is my disclosures. I've received honorarium as well as advisory board participation. The outline of my lecture is as follows. I'll give a brief introduction about the metastatic breast cancer and the magnitude of the problem. Then the overview treatment landscape for ER positive, HER2 negative metastatic breast cancer. And the focus of my talk will be the addition of CDK4/6 inhibitor and how it improves both progression-free survival, overall survival, and in the first and second line of therapy. And then briefly the options after CDK failure. So metastatic breast cancer, this is a Globocan from WHO. You can see 18.1 million new cases per year was diagnosed in 2018. The range of metastatic breast cancer is from 5 to 15% or even higher in some other countries. Our data from the kingdom is as follows. Consistently, in the Saudi Cancer Registry, we have seen about 15 to 18% of cases diagnosed in the kingdom are metastatic disease. That roughly translates about 1,000 cases per year, and that is 2016 data. The median age is very young, so this disease results in considerable impact on the family as well as those working females. Those who have early disease, about 50% of them will have metastatic disease later on. The hormone receptor positive represents 2/3 of the breast cancer in general, and this is similar for metastatic disease as well. Metastatic disease is not a curable disease in general, except for very few with localized disease, and therefore improvement morbidity and mortality and quality of life is extremely important for these patients. You can see that this is a data from UK. This is more recent till 2017. You can see stage 4 disease is survival was between 10 to 20%. And then this new dots, which is presenting the more updates, you can see the survival improving to 30 to 40%. And this is where we stand, or this is the baseline survival prior to CDK error for stage 4 disease. This is my slides. I try to make it very briefly. For more than 50 years, we have tamoxifen, which is called SERMs, or selective estrogen receptor modulators. Then it took another 30 years to get the AI. Then we have the approval of everolimus as an mTOR inhibitor 2014. But the major breakthrough came from 2016 to 18, where we have CDK inhibitors. And we have 3 approved CDK inhibitors. We have data of PARP inhibitors, talazoparib, olaparib, and this is again in a selective group who are BRCA1 or 2 positive or mutant. Then we have the 500 milligram fulvestrant. Fulvestrant is an old drug since 2002, approved 250 milligram, but really it became interesting with the Falcon data. Then we have the combination of AI and fulvestrant, and some of our colleagues there is also pointed out to the PIK3 kinase inhibitors, which is specific for those PIK3 mutant patients. This is the Falcon study. You can see no difference in overall response rate, but a significant improvement in progression-free survival. And this is what led to approval of this medication. And mainly it's seen in non-visceral disease. What about the combination? We have multiple studies, some of them positive, some of them negative, but overall there is a 3-month difference in progression-free survival in favor of combination of AI plus SERD, which is fulvestrant. And one of the study, Mehta, he recently published update in the New England Journal with a 5-year survival of 50% versus 42% with AI alone. So definitely this is one of the options which was mentioned earlier. I think this graph was shown before. What leads to resistant hormone therapy is this mechanism. One of the important mechanisms of resistant hormone therapy is overactivation of CDK4 and 6. We have two molecules, retinoblastoma protein and E2F. The retinoblastoma is inhibitory and E2F is stimulatory to the cell cycle. So if the cyclin D4 and 6 are active, retinoblastoma is phosphorylated. It cannot combine the E2F, which is active and induces cell proliferation, and the cell will divide. So now we have, as mentioned, the three CDK approved, and whenever we say Paloma, it refers to palbociclib. Whenever we say Monarch, it refers to abemaciclib, and Mona Lisa obviously referred to ribociclib. We have at least 5 studies with AI combination, and one of them is purely in the premenopausal group, which is very relevant to our population, which is the Mona Lisa 7. We have Mona Lisa 3, which allowed one prior line of endocrine therapy. So basically, it includes both first and second line patients. What is consistent with these 3 trials? Doubling of progression-free survival. You can see on average 22 to 24 months with the addition of CDK to the AI compared to AI alone. And this is consistent across all the 3 studies. I'll go more into details about the Mona Lisa 7 because this is very relevant to our population. About 700 patients who had no prior endocrine, strictly peri or premenopausal women who have advanced breast cancer, were randomized to ribociclib with AI or tamoxifen. Whoever received tamoxifen, both who received tamoxifen and AI have to have joserelin, which is LHRH agonist, to make them postmenopausal, versus the standard therapy, which is TAM or AI plus joserelin. And this is to show that the patients are well balanced in both group. And you can see the progression-free survival, 24 months versus 13 months, in favor of adding ribociclib to endocrine therapy. And the interesting part, which is all of us are awaiting, as I showed you, the survival of 30% at 5 years. Now, at almost 5 years, we are seeing 70% survival compared to 46%, which is better than the standard of care and can be explained by many, including better health care. So there is a 29% reduction of death with the addition of ribociclib to endocrine therapy, which is a very, very important result. One of the things which matters for many of the women who have breast cancer is the concern about chemotherapy. And you can see that the time to subsequent chemotherapy is also delayed with the addition of ribociclib to endocrine therapy. At 42 months, 65 or 66% have not received chemotherapy compared to 49% in the endocrine therapy group alone. What about the safety? I think this was pointed out. You have to aware about these 3 toxicity: hepatotoxicity, neutropenia, which is significant, but mainly grade 1 and grade 2. You can have grade 3, and the prolonged QT interval. Fortunately, it's about 2%, but you have to be very careful of adding or reviewing the medication of these patients, as other medication which can cause QT prolongation may have significant interaction. What is also very important for a patient with metastatic, as mentioned, is the quality of life. And the quality of life is maintained with adding CDK4 inhibitor. Indeed, it's better quality of life of those patients who are responding. So at least there is a 10% improvement in quality of life by adding Cdk inhibitor ribociclib to endocrine therapy alone. Then the Mona Lisa 7, as I pointed out, it included treatment naive, time to treatment failure interval more than, this is what we define as endocrine sensitive disease, and then who have one line of therapy, endocrine therapy before, and these included different patients. So early relapse, so this is what we call primary resistant, those who recur within 12 months. They are not considered endocrine sensitive. So it included both endocrine sensitive and endocrine resistant disease, which is important in breast cancer management. This is the statistics. I'll skip that for the sake of time. And again, very consistent result, 21 month versus 12 month, which translate almost 50% reduction in progression at about 3 years. And this is the first line, de novo disease, early relapse, and second line, that means those including those who have primary resistant disease. You can see, again, there is 50% reduction in progression, whether the patient is in the first line, have an early relapse, or have a primary endocrine resistant disease. And again, we have overall survival, 28% reduction of death. You can see 60% survival versus 65%, 45% survival in the endocrine therapy alone. And this is by, again, for those who are resistant to endocrine therapy or primary resistant, have similar outcomes. This is also what matters to the patient. Time to the first chemotherapy, again, is delayed with the addition of CDK4 inhibitors. Similar safety, and one thing I have to point out, which is very rare, but it is a black box warning, is lung toxicity, which have been recently highlighted with this, all CDK4 inhibitors. And again, you can see quality of life in Mona Lisa 3 is also in the favor of adding CDK inhibitors. What about post-AI? We have also many studies, including all the CDK inhibitors, including monotherapy. I'm not going to go into details. You can see similar hazard ratio, 50% reduction in progression, although you can see the response rate is slightly less, and the time to progression average about 16 months compared to 22 months, but still the proportional reduction in time to progression was in favor of adding CDK to fulvestrant. I'm going to skip because there is a full lecture about abemaciclib. And again, to be fair, this also abemaciclib showed a survival advantage over endocrine therapy alone, fulvestrant in the second line. So what is the optimal therapy after CDK failure? There's no standard of care yet. And mTOR is one of the options, which is again based on institutional experience. The BELIEVE or BYLIEVE study was already presented. And let's not forget, at the end, there is chemotherapy. So all these patients, if they fail all lines of biological agents and hormonal therapy, then you start with a new line of chemotherapy for these patients. So this is the ESR mutation. We don't have any targetable medication for ESR mutation, but we do have a target for PIK3, which is seen in about 30% of breast cancer patients. SOLAR-1 was presented, but what I want to highlight here, one thing, that they included both PIK3 mutant and non-mutant cases and added alpelisib to fulvestrant. This was after AI failure. Sorry, it was in the first line. And you can see that the progression 11-month versus 5.6-month improvement in progression-free survival. For those who are PIK3 non-mutant, there is no statistical difference, again, proving the concept that it works in PIK3 mutant patients. And this is the BILEAF study, which is 3-arm study. Only one arm is reported, where all of them had CDK before and failed AI in the metastatic setting, were randomized to fulvestrant alone versus alpelisib plus fulvestrant. And we can see this was highlighted before. At 6 months, 50% have not progressed, and the average progression-free survival was 7 months. So now, if all fails, then let's not forget chemotherapy. And we have 2 ways to use chemotherapy. One is a single agent chemotherapy, which is preferred in most of the patient, or combination chemotherapy when you are considering a more rapid response. But in generally, these are the categories of medications: taxane, anthracycline, antimetabolites, anti-microtubule inhibitors, and platinum agents. These are the active medication breast cancer. So to conclude, breast cancer is a common problem with considerable morbidity and mortality, including in the Kingdom of Saudi Arabia. The improved survival led to CDK4/6 in combination of AI and fulvestrant to be new standard of care in the first and second line management. There is no standard of care after CDK failure, but mTOR inhibitors, chemotherapy, and PIK3 kinase are choices. And lastly, I could say for those who are BRCA1 or 2 mutant disease, you could also consider PARP inhibitors as a single agent compared to chemotherapy. So thank you very much. With this, I conclude my talk.